So let's go back to Joe. We're going to do jumps 2 and 3 here. 4 weeks pass and Joe returns for follow-up. His blood pressure's 150/90, a little bit better. He's been unable to quit smoking or drinking beer, but has cut down. Lost 3 pounds, walking 1 mile after work every evening. He has not gotten his lab tests done. So what is your next step pharmacologically? Think about, again, your rationale, mechanism of action on effect, and the effect on the BP equation. I purposefully have not told you exactly what drug I would treat this patient with first. I can provide some thoughts following this lesson, but you might have chosen at first to give him a diuretic, as is indicated in the guideline, or you may have gone with an ACE inhibitor, in which case you're going to take a look at a different part of the equation. And at this time, I want you to consider what lab tests you want taken and why. Think again about the rationale for any laboratory testing, having to do with not only what other risk factors he may have from a cardiovascular standpoint, but also monitoring the drugs that you have chosen to administer. He has done some lifestyle changes. This data comes out of the JNC7 document, and we know that by reducing weight, we can reduce the blood pressure reading 5 to 20 millimeters of mercury per kilogram of weight loss. That's 2.2 pounds. That's not a bad deal. If he lost quite a bit of weight, he might be able to drop his blood pressure significantly. As mentioned before, this is our approach with children. Nutrition, the DASH diet, which is low in sodium as well as fat. And we can see a small reduction there, and sodium reduction can help as well. Increasing physical activity can reduce blood pressure by 4 to 9 millimeters mercury. I've seen it actually do a little bit better with pretty intense aerobic activity. So they're talking about aerobic here. And alcohol limitation as well. Just a few more notes from the trenches. Thiazides generally, as I said, have create a modest decrease in blood pressure through not only taking off fluid, but a little bit about decreased peripheral vascular resistance. They do worsen insulin resistance, so we worry about that with our type 2 diabetics. We'll talk about that more in another lesson about insulin resistance. Interestingly, they may be a 2-minutes-in-1 drug, especially chlorthalidone, is indicated for preserving calcium in our patients who have osteopenia and osteoporosis. There has to be a little bit of evaluation of whether or not calcium is being wasted. This is done by special testing, but again, that may be a benefit. Beta blockers, again, lower on the protocol as far as the drug choice, but remember that when your beta blockers are in place, adrenaline can't affect the heart, so you may see some blunting of things like increased pulse rate with stress, etc. This is beneficial, as we sometimes use these drugs to help people with things like stage fright. It also worsens insulin resistance, but we don't want to avoid it because diabetes actually has been shown back in JNC7 was one of those compelling indications for the use of beta blockers because of its somewhat cardioprotective feature, which is why we use it as a secondary preventive measure after myocardial infarction. We want to wean it slowly because when we abruptly withdraw, we get this adrenaline kind of rush, and it's very uncomfortable for the patient, and it can be more than uncomfortable. Remember too that these decrease heart rate and stroke volume. That is their mechanism of action and their impact upon the blood pressure equation. We're not going to talk a lot right now about alpha-1 blockers. Um, Alpha-1 blockers reduce peripheral resistance. They are also used concurrently. The Zosyn drugs used in a condition of benign prostatic hypertrophy. We'll talk about that later. But if you combine them with a beta blocker in a drug called carvedilol, it's very cheap but has to be taken twice daily. This may be a good drug for people with diabetes. It works on all three elements of the equation. And it's thought that alpha blockers increase insulin sensitivity just a bit. Remember again that ACEs are considered an or drug only with ARBs. So we don't combine them. They do decrease resistance, peripheral vascular resistance, as we've already discovered through the renin system. We do want to be cautioned in some rare cases of bilateral renal artery stenosis, which is a secondary hypertension found in the young. And yet they are renal protective until the patient becomes hyperkalemic or has too much potassium on board. At that point, we refer the patient. We're not going to be treating these patients in primary care. Again, I mentioned earlier, there is a cough with the ACEs, and the ARBs can be your alternative. We have more and more data about ARBs these days and finding that they really are just as effective and safe. Lisinopril of the ACEs is the only truly 24-hour med. There is such thing as a direct renin inhibitor, and those decrease peripheral vascular resistance. I mentioned that earlier. We're not going to get into that particular group of drugs. They're newer. Calcium channel blockers decrease peripheral vascular resistance. They are the most potent. We don't adjust for ethnicity. In fact, in the new JNC8, they are the drug of choice for the Black population. I mentioned already that there are swollen ankles. It's not due to heart failure. We treat with TEDs, not meds, TEDs being the stockings that you put on like you learned in fundamentals. There's some other drugs too. Within that class, the calcium channel blockers, we have amlodipine, which I already mentioned, which is very common and inexpensive. There are drugs like diltiazem, which are the non-dihydropyridines, but they are potent CYP450 inhibitors. Therefore, we have to really watch out for interactions. I already touched base on the potassium-sparing aldosterone. We do use that occasionally. It does reduce peripheral vascular resistance in volume. There is a side effect of gynecomastia long-term, and which makes it not as attractive for the male patient. Alpha blockers, we already talked about that, and central acting PVR reducers like clonidine are very sedating. They also have been used off label for years as a anxiolytic drug, and we also, as a side note, we use aldosterone in pregnancy sometimes. So Joe returns after 4 more weeks. His blood pressure is 140/80. I think you might like that. You might have made a decision back in the last jump, which I would agree with, to add a second agent. So if you had started with an ACE, you might add a little hydrochlorothiazide, even just a whisper sometimes helps. Or you might have started with the hydrochlorothiazide and then added the ACE inhibitor or the ARB. He has done some lifestyle changes, and we now see that his lipid profile results have been returned. And we'll take a look at those in a minute. Lab chemistries, which I mentioned earlier, things that measure liver and kidney function, are within normal limits, so we know his electrolytes have not been impacted by any drug. The lisinopril, if you chose that as an ACE inhibitor, might retain a little bit of potassium. The hydrochlorothiazide might waste a little, but that's all fine. So now we want to figure out what this lipid profile tells us. Now, lipids are just one part of the risk factors for cardiovascular disease, and that's our goal here, is to reduce risk factors. Can't change his age, can't change his gender. We certainly can reduce the tobacco use, and I should say that even though smoking is listed by the Framingham study as a risk factor, all tobacco use is, as nicotine is a potent vasoconstrictor. And of course his hypertension, which we are getting under control, his total cholesterol, and then his HDL is kind of an opposite risk factor. We know if HDL is low, we are concerned, and that can be improved. HDL can be improved by physical activity, for one. So we give him credit for HDL over 60, and that's kind of an opposite than a risk factor. So there is an estimator that I like to introduce you to, and we're going to try it out for Joe right now. You can also get this as an app on your cell phone, and I'm going to move the screen a little bit so we can see the pieces that we're going to choose for him. He is a male. He's 59. He is white. His total cholesterol was his HDL cholesterol was 50. His total cholesterol is 208. He's not diabetic. He is treated for his hypertension, and we now have a blood pressure of 140 systolic. He's still a smoker, so we're going to call him a yes. So his 10-year risk for vascular disease is 18%, and his lifetime risk is very high at 69%, probably because of the tobacco. And then in this next screen, you'll see that we do recommend a moderate to high intensity statin drug. Statins are the only drug of the various anti-cholesterol drugs that are mentioned in these guidelines at this time. There are other ones. I'm not going to review those today, but they do work to a degree. So the other thing to mention here is if his LDL, which we don't put into the calculator, but if that's over 190, we just go straight to a statin and we don't worry about the other pieces of the risk estimator. So it's determined here that we want to go ahead and start a lipid, anti-lipid drug. Now remember that this should be a shared decision-making process with the patient, targeted therapy to reduce their risk, and of course there is risk of treatment. Over time, the statins are implicated in effects upon the liver, and the worst of those developing a case of rhabdomyolysis, and people will have some side effects, sometimes complaining of muscle aching, etc., but that's not a true rhabdo. So here our choice is going to probably be a statin. In the case of persons who are intolerant of statins, we do have other choices, as I mentioned, and there are some fibrate drugs, and niacin is another drug that is used. I think those are addressed in your textbook. Again, generally very much less reduction of cholesterol levels. Of course, we're going to look at the the statins in a minute. The thing you want to keep in mind with the statins, all except Pravachol or pravastatin, is that they all are potent CYP450 reactors, so we want to be careful if he is on a lot of other medications and do a cross-check for interactions. So this just gives us a summary of how the drugs work. These are the HMG-CoA reductase inhibitors, or more commonly known as the statins. This little slide and its attendant notes, which you will see if you open up the PowerPoint online, will give you the information that tells you the mechanism and how these actually work. But they are potent. Lipitor or atorvastatin is now on the $4 list and is considered the most potent of all these medications. That concludes this section of the slides, and there will be one more set of slides to review for your lesson.